Okay, the normal calcium level is 8.5 to 10.5 milligram per deciliter. That is help. That level is maintained by three hormones. Which are the three hormones that maintain your calcium levels in the body? One is parathormone. Another is
Calcitonin.
very good. Third one is your vitamin. Which vitamin?
D. D.
D3. Okay, 125 dihydroxy vitamin D3. That is the most active form of D3. Okay, so ये तीन hormones तुम्हारे calcium levels maintain करते हैं. Okay, in the body. So what is we need to know the individual function, physiology of it. So calcitonin का क्या काम है? Okay, so parathormone. Since our discussion is parathyroid, parathormone क्या करता है? It increases the calcium level or decreases in the blood. Okay, in the blood I'm talking. It increases the calcium level. Okay, it increases the calcium absorption. Okay, and decreases phosphate absorption by acting mainly on the kidney. Okay, तो you know that वो bones पे भी osteoclast बनाता है. वो कभी कभार अगर अपने body में या blood में calcium level कम हो जाएगा, it will make osteoclasts. You know that osteoblast and osteoclast. Osteoblast is responsible for depositing calcium on the bone. Osteoclast will consume. Okay, so it will consume or take away the calcium from the bone and it will put it in the blood. Okay, so that is the one way. Okay, but that way is used only when your kidney and substate. मेरे calcium levels I have already absorbed a lot of it and there is no other option. The only option is to increase the calcium level by eating up the bone. Okay, so parathormone हो गया. Then 125 dihydroxy vitamin D3 वो क्या करता है? How does it maintain calcium level? Does it increase or decrease calcium levels in the blood? Okay, it again increases.
Increase.
Very good. It again increases and it decreases the phosphate absorption. Okay, it again acts in GIT and kidney, right? We know that vitamin D3 is absorption from the kidney. From GIT अगर तुम्हें उसको absorb करना है, so you need vitamin D3. Okay, so from kidney, from GIT, vitamin D3 तुम्हारा absorb करने में help करेगा. And calcitonin, what do calcitonin do? Does it increase or decrease? है ना, इतना सब कुछ increase कर रहा है तो कुछ decrease करने वाला भी चाहिए. It decreases. Okay, so it decreases calcium absorption, it decreases phosphate absorption by acting on the kidney. Okay, now let us go to the most important topic in surgery, where when we come into picture, where we need to operate on the patients, because more of this is again medicine. Why are we concerned? Okay, so we are concerned whenever there is a condition of hyperparathyroidism, and that is either because of the adenoma. Okay, parathyroid gland का adenoma हो गया या hyperplasia हो. Okay, so what is the difference? Adenoma और hyperplasia, ये दो अलग अलग चीजें क्यों बता रहा हूँ? These are basically the etiology, है ना, of hyperparathyroidism. Adenoma क्या रहेगा and hyperplasia क्या है? So adenoma could be a tumor of just one single gland, maybe, है ना, चार में से कोई भी एक gland बड़ा हो रहा है ना, that is becoming a tumor, benign tumor. So adenoma हो सकता है उसका, and hyperplasia can be of all the four parathyroid glands. And so hyperplasia are more common with your मेन syndrome है ना, जहाँ पे सब पूरा gland, सब चारों glands are getting increasing in size and are secreting more and more parathyroid. Okay, so we know that hyperparathyroidism is divided into primary, secondary, and tertiary. Okay, so primary, as we know, anywhere primary मतलब क्या? Primary is the problem in the gland itself. So the primary cause is due to can be because of adenoma or hyperplasia. Okay, adenoma or hyperplasia. Secondary hyperparathyroidism is क्यों हो रहा है? Because of some reason your calcium levels in the body are decreasing, the blood are decreasing too much, and that is causing increased stimulus to the parathormone, to the parathyroid gland to secrete more parathormone. Okay, so secondary hyperparathyroidism is because of decreased level of calcium in the blood, So it is increasing the parathormone secretion. And tertiary is because of calcium becoming normal, okay, but still there is autonomous secretion of parathormone. Okay, this is very rare. It usually occurs after 1 year of kidney transplant. Okay, it occurs after 1 year of kidney transplant. इसमें क्या हो रहा है? Calcium normal हो गया, but फिर भी now the gland has become autonomically secreting more and more parathormone. Okay, so this occurs after renal transplant and renal failure. This is very rare. So primary or secondary ज़्यादा करके मिलते हैं. Okay, so in primary hyperparathyroidism, okay, what are the incidents? Incidents is more commonly seen in females more than males. Okay, and it is found almost in the fifth decade of the life. This hyperparathyroidism, primary hyperparathyroidism. Okay, अगर मैं primary बोल रहा हूँ तो again, what is the problem here? There is intrinsic activity in the gland is problematic. Okay, so it is either adenoma or hyperplasia. It is either adenoma or hyperplasia, and again इसमें इंसिडेंस क्या है? अडिनोमा का इंसिडेंस इज फार मोर देन हाइपरप्लेजिया. अडिनोमा 85% ऑफ द पेशेंट्स. ओके, बहुत सारे. रिसेंटली one of my senior surgeon's wife, okay, she was diagnosed of hyperparathyroidism, and initially hyperparathyroidism जब present होता है समझ में ही नहीं आता कि पेशेंट को hyperparathyroidism है, because the symptoms I will tell you, they are very vague. They are very vague. Okay, so you need a high degree of suspicion to diagnose this condition of hyperparathyroidism. Again, it was wife speech, it was female, swift decade, everything fits. Okay, so ये जो solitary adenoma होता है, what is hyperplasia? Solitary adenoma के incidences ज्यादा है. Usually it occurs sporadic. Okay, it is not related to any congenital problem or hereditary issues like hyperplasia. है ना? Why? As I told you, hyperplasia ज्यादा करके men syndrome में होते हैं. So men is what? Multiple endocrine neoplasia. Okay, we'll be discussing men syndrome also. So hyperplasia, usually it is hereditary, while solitary adenoma usually is sporadic. Okay, and again, when I say usually, क्यों usually तुम देखोगे तो surgeons, physicians, clinicians, हम कभी भी ये words बहुत ज्यादा use करते हैं. Why? Because in medicine nothing is a god's thumbs rule. Okay, कुछ भी पत्थर की लकीर नहीं है ना? ये भी हो सकता है, ये भी हो सकता है, ये भी हो सकता है. ओके, सो हो सकता है वाली चीजें बहुत ज्यादा. सो मैं जब बोलता हूँ कि यूजुअली, तो ज्यादा करके ये होता है, बट अगेन नॉट अ थंब रूल. मैं सॉलिटरी अडिनोमा भी फैमिलियल हो सकता है सेकेंडरी टू मेन 1 और मेन 2. ओके, नो थंब रूल इन मेडिसिन और सर्जरी, मेडिकल फील्ड, कोई भी अपनी फील्ड उठा लो, कुछ भी थंब रूल नहीं. ओके, सो हाइपरप्लेजिया कैन मोस्टली इट इज familial. Solitary mostly it is sporadic, but can be associated with familial disorders like men 1 or men 2A. Okay, anyone knows the clinical features, or what is the mnemonic we use to understand the symptoms of hyperparathyroidism? There is a rhyming word of which ends with "ons" in all the 4 different features.
Groans, moans, uh,
Yes.
broken bones, ऐसा.
Yeah, close. Okay, so it goes by the mnemonic of bones, stones, abdominal groans, and psychic moans. Okay, so bones, stones, abdominal groans, and psychic moans. So bones का क्या प्रॉब्लम है? As I told you, अगर हाइपर पैराथायरॉइड हो जाएगा तो पेशेंट को बहुत ज्यादा पैराथायरॉइड हो जाएगा. क्या बनाएगा वो? ऑस्टियोक्लास्ट्स बनाने लगेगा. जब ऑस्टियोक्लास्ट्स बनेगा तो क्या होगा? द कैल्शियम फ्रॉम द bones will start going. Okay, and it will be start going in the it will come in the blood. Okay, so this results into a tumor of osteoclastoma due to excessive production of osteoclast. Also, because of excess of absorption of the bones, what will happen? There will be something known as brown tumor, which is osteitis fibrosa cystica, osteitis fibrosa cystica. And what is the hallmark that you see on X-ray? On X-ray in skull, what is the hallmark that you see in parathyroid? स्कल में क्या चेंजेस दिखते हैं एक्सरे पे?
Salt and pepper
Very
appearance.
good. Salt and pepper appearance that you see on the X-ray on the of skull. Okay, so salt and pepper appearance in skull again is because of deposit excess of absorption of calcium from the skull bone by the osteoclasts. Okay, so these are the 3 features of bones. Now stones. Okay, so we know that mostly all of your stones in the body are pathological stones are made from calcium. Okay, so अगर excess of calcium होगा So it will give rise to renal stones or kidney stones, pancreatic stones. Okay, तो stones वाली ये. So are you seeing ये देखो bone का problem हो गया. Stones अभी kidney stones के features रहेंगे patient को. Renal calculi, what all features will it give? The patient will have pain in the right iliac or left iliac fossa wherever the stone is. The stone might trickle down into the ureter. There will be radiating kind of pain. There will be burning micturition. See, hyperparathyroidism कहाँ and stones कहाँ. Okay. बोन्स के प्रॉब्लम्स कहाँ. बोन्स में पेशेंट को इजी फ्रैक्चर इजी फ्रैक्चर हो जाएगा है ना. बोन्स विल बिकम ब्रिटल because of the excess of osteoclast. Okay, and abdominal groans. Okay, so because of the pancreatic stones, there can be pancreatitis as well. Okay, there will be peptic ulcer and psychic moans. Patient को symptoms आ सकते हैं mania and depression के because of because of increased calcium levels. Okay, so there is psychic moan. So all these are very unrelated symptoms to each other, but they are because of this primary hyperparathyroidism. Okay, so hyperparathyroidism in general, primary or secondary or tertiary, ऐसे ही features देंगे. It is just that what is the etiology of it, it changes. Okay, and thus your management also changes. Okay, so other clinical features which are associated with hypercalcemia is that the patient will have hypertension, there will be left ventricular hypertrophy, there will be muscle weakness, fatigue, and your calcified, or there will be deposition of this calcium in the blood vessels, okay, and in the soft tissue. Okay, अभी hyperthyroidism, hyperparathyroidism में, as we know that it can cause hypertension. Okay, and because of this excess hyperparathyroidism, there can be something known as hypertensive crisis, which is stimulated or which occurs after the calcium levels in the body becomes more than 14 milligram per deciliter, which becomes more than 14 milligram per deciliter. So hypertensive crisis हो जा रहा है कि बहुत ज्यादा पेशेंट का बीपी बढ़ रहा है, बीपी increases up to 210 to 20 mmHg and it is an emergency situation. Hyperparathyroidism में एक ही emergency है. Okay, thyroid में कौन सी है? What is the thyroid emergency that we know?
Thyrotoxicosis.
Myxedema, coma.
Myxedema coma.
Myxedema coma, that is one. And in hyperthyroid,
Thyroid storm.
very good, thyroid storm. Okay, so these are the two emergencies that are there with thyroid. Okay, one emergency that is there with your parathyroid is hypertensive crisis. Is hypertensive crisis where your calcium level is more than 14 mg per dl and your systolic BP increase to 220 mmHg. Okay, how will you manage this? How will you manage? Initially, you start by giving IV fluids. You try to dilute, है ना. तो तुम जब फ्लूइड ज्यादा दोगे तो 200 ml per hour के रेट से फ्लूइड दो तो apparently your calcium levels will be decreased. Okay, you give calcitonin because we know that calcitonin is helpful in decreasing the calcium levels. It will push the calcium out of your kidneys. Okay, you give bisphosphonates to maintain your calcium levels in the bones. Okay, you give steroids and early parathyroidectomy. Early parathyroidectomy that is the initial or the entire treatment protocol that we follow whenever there is increased calcium levels secondary to this parathyroid stop or hyperparathyroidism. Okay, so now let us diagnose. Okay, primary hyperparathyroidism तुम suspect कर रहे हो. Okay, say I will give you my personal example. Okay, I have been diagnosed with renal calculi and I have been operated for ureteric calculi twice, and still in the third time I have a kidney stone in my right kidney. Okay, which is a 1.5 centimeter in the lower pole. Obviously, in my patients like me, you need to do parathormone. है ना, तो parathormone करना पड़ेगा. और तुम कैल्शियम लेवल्स भी देखोगे ना मेरा. तो what is the biochemical picture that you are expecting in me or in patients like these? What should be your calcium levels?
High.
High, very good. High. Okay, so calcium is high, phosphate is low, serum parathyroid is more. Okay, we need to discuss this biochemical picture in all the three types of hyperparathyroidism because it is slightly different in all three, and this helps you understand कि कौन सा parathyroid hyperparathyroidism patient तुम्हारे पास लेके आए. Because see, patient will not come from here. Okay, हम कभी भी जब सोचते हैं तब हम कभी भी आंसर या टॉपिक पढ़ते हैं, वी स्टार्ट फ्रॉम दिस, वी ऑलरेडी नो द डायग्नोसिस. ओके, व्हेन अ पेशेंट, वी आर डीलिंग विद द पेशेंट विल कम टू यू विद दिस and then you need to identify. Okay, so it is very important that in investigations we understand certain things which will help us in identifying the cause. So this is the beauty of being a good clinician, that तुम अगर investigation भेज रहे हो तो तुम्हारे दिमाग में 2 या 3 differentials आने चाहिए, और 1 या 2 इन्वेस्टिगेशन पे तुम्हें पता चल जाना चाहिए कि पेशेंट को क्या है. You don't have to do 10 investigations. So you start thinking differentials when the patient comes to you, and you should know that one small test or one test or max to max 2 tests जिसमें तुम्हें diagnosis में. Okay. Don't practice, that is what I mean, that don't practice evidence based medicine, है ना. तुम 10 15 20 25 चीज मत करो तब जाके तुम no, everyone can do this. No, anyone can do this. Okay, we are doctors, we are clinicians. तुम्हें 1 या 2 टेस्ट में investigations, always remember, they are not for diagnosis, they are to support your provisional diagnosis. Provisional diagnosis तुम्हारे history और examination पे आ जाना चाहिए. Okay, so what other things you will do? You will do 24-hour urine calcium. That will help in that will be either decreased or normal. Okay, and your alkaline phosphatase. Okay, alkaline phosphatase will be increased because osteoclasts, osteoclasts are acting on the bones. They will cause more and more alkaline phosphatase in the blood, and hence alkaline phosphatase is increased in this. And it is also increased in which other condition? We know that alkaline phosphatase is not that sensitive because बोन्स में भी सिक्रीट होता है. और कौन सिक्रीट करता है अल्कालाइन फॉस्फेटेज?
liver,
लिवर. कैन यू बी मोर स्पेसिफिक?
obstructive jaundice,
हाँ, सो लिवर में ऐसे नहीं आ रहा है अल्कालाइन फॉस्फेटेज. ऑब्स्ट्रक्टिव जॉन्डिस में कहाँ से आ रहा है?
the biliary tract,
Yeah, so the mucosa of the CBD, है ना, mucosa of the common bile duct is secretes alkaline phosphatase. Okay, इसलिए तुम जहाँ तुम्हें stones आ रहा है CBD में, colon, you have a case of choledocholithiasis या cholangitis, है ना, वहाँ पे तुम्हारा alkaline phosphatase बढ़ा हुआ मिलता है. Maybe there's a tumor which is in the bile duct, so that will give you raised alkaline phosphatase. Okay, so it is specifically getting secreted from the bile duct mucosa. Okay. Then अभी ये तो हो गया biochemical investigations. As we know that we always divide the investigations into 3 parts. The first investigation is investigation to confirm the diagnosis. Second group is investigation to treat the disease, investigation to stage the disease or grade the disease. And the third is investigation to treat the disease. And whenever you're dealing with investigation to confirm the diagnosis, okay, you will always go from non-invasive to invasive. Non-invasive to invasive. And non-invasive में you have 2 things, either radiology और biochemical. Okay, इसके अलावा तो तुम्हारे पास कुछ है नहीं. जब तुम इन्वेसिव की बात करते हो, yes, you have colonoscopy, OGD-scopy, you have biopsy, है ना, different ways. So हम जब नॉन इन्वेसिव सोच रहे हैं तब हम बायोकेमिकल करेंगे और या रेडियोलॉजी. ओके, और बायोकेमिकल में वी सॉ दैट हम कैल्शियम लेवल्स देखेंगे, हम पैराथायराइड देखेंगे, हम ये देखेंगे, यूरिन में कैल्शियम देखेंगे, ये सब देखेंगे. दैट इज बायोकेमिकल. नाउ यू नीड टू थिंक ऑफ समथिंग like radiology that will help you diagnose कि भाई ये पैराथायराइड में एडिनोमा है. So this is how we clinicians also think, and this is how you are also expected to answer in your vivas. या तो तुम आंसर जब लिख रहे हो तभी भी तुम ऐसे सोचोगे ना और ऐसे डिवाइड करोगे, तब तुम्हें याद नहीं रखना पड़ेगा कि ये इन्वेस्टिगेशन में क्या था, ये था या ये था, है ना. अभी मुझे पता है कि ऑब्स्ट्रक्टिव जॉन्डिस का पेशेंट है तो वहां पे एलएफटी बहुत इंपॉर्टेंट हो जाएगा. फिर एलएफटी में ऑब्स्ट्रक्टिव जॉन्डिस क्यों हुआ है, तो एलएफटी मुझे पता चल गया ये ऑब्स्ट्रक्टिव जॉन्डिस का केस है, तो देयर इज पोस्ट हेपेटिक सम ब्लॉकेज. तो वहां पे फिर मैं सोचूंगा व्हिच रेडियोलॉजी विल हेल्प मी डिफरेंट गेट टू द रीच टू द प्रॉपर डायग्नोसिस. तो इनिशियल इन्वेस्टिगेशन आई विल डू अ यूएसजी, एंड देन आई विल गो फॉर MRCP, एंड देन ERCP इफ इट इज इंडिकेटेड. ओके, अभी हर्निया में जब तुम हर्निया डायग्नोस कर रहे हो तब मुझे CBC, LFT, RFT, कोई भी बायोकेमिकल इन्वेस्टिगेशन इज नॉट गोइंग टू हेल्प. I won't do that, at least not initially. I want to do some radiology investigation to confirm. Okay, we know that तुम बोलोगे नहीं सर, here is the clinical diagnosis. You are right, but in today's day and time, तुम जब मेडिक्लेम में पेशेंट को ऑपरेट कर रहे हो तब तुम्हें उनको प्रूफ चाहिए कि भाई हर्निया था, तो तुम्हें उस रीजन से करना पड़ सकता है. ओके, और समटाइम्स you are dealing with incisional hernia. There are many defects. तो you on clinical diagnosis, on clinical examination, तुम्हें एक आध डिफेक्ट के बारे में पता चलेगा. You won't be able to plan your management completely just on clinical examination. Then you have to do a CT scan. Are you getting it? So whenever you are dealing with anything, whether you are writing your answers, whether you are answering your viva, or you are dealing with actual patients, You think of those investigations, वो एक इन्वेस्टिगेशन तुम्हें डायग्नोसिस तक रीच करने में हेल्प। तो यहाँ पे हमने देख लिया बायोकेमिकल इन्वेस्टिगेशंस क्या है। नाउ वील डू सम रेडियोलॉजिकल इन्वेस्टिगेशन। सो कैन यू टेल मी व्हिच रेडियोलॉजिकल इन्वेस्टिगेशन you would like to start with? Okay, I have to think, yeah, you would like to start with something which is less cost effective, easily available. Okay, तो सोनोग्राफी और एक्सरे में ट्राई करोगे तुम कुछ ना कुछ पता कर पा। ओके, यहाँ पे आई वुड लाइक टू डू यूएसजी नेक। यहाँ पे आई वुड लाइक टू डू यूएसजी नेक बिकॉज सी इट इज अ सुपरफिशियल ग्लैंड। अगर कुछ बड़ा रहेगा तो मुझे दिख जाएगा उसमें, जैसे कि थायराइड के पीछे ही है, अगर वो एडिनोमा है या हाइपरप्लेजिया है तो चांसेस है कि पता चल जाए। तो इनिशियली आई वुड लाइक टू डू अ यूएसजी नेक। Then there is a specific investigation, special investigation. Can you tell me which another special investigation is there for parathyroid? Is a scan. Okay, there is system EV scan. Okay, what is the principle of system EV scan? It picks up oxyphil content. Oxyphil content को जहां जहां oxyphil content है वो system EV scan पकड़ता है. Okay, we had discussed one carcinoma in thyroid जहां पे oxyphil content ज्यादा था. Can anyone tell me what was that? Thyroid carcinoma with increased oxyphil content, because that is giving a false positive test here. System EV, we are doing this for parathyroid, but if that problem is there, it will give you a false positive test. Okay, it was Hurthal cell carcinoma. It was Hurthal cell carcinoma or adenoma. Okay, उसमें भी oxyphil content ज़्यादा रहता है, so it is false positive of system EV is Hurthal cell adenoma. We know that parathyroid में oxyphil है, तो we are using system EV scan. Okay, so system EV scan करोगे and USG. These are the initial investigation because hyperplasia है, बहुत बार तुम्हें USG पे नहीं दिखेगा. अडिनोमा है, बड़ा हो गया ग्लैंड, तभी दिखेगा, एक आध ग्लैंड दिख गया तो भी दिख गया. एंड ऑलवेज सी यूएसजी इज समथिंग व्हिच इज ऑपरेटर डिपेंडेंट. Okay, so you need a good sonologist to do those investigations for you. Okay, and sonologist है तो मतलब someone who is just a beginner, उसको बहुत सारी चीजें बहुत evident वाली नहीं दिखी, मिस कर. और someone who is very good with it, it is said that sonography or a USG in good hands is equivalent to a CT scan. Is equivalent to a CT scan because this, if you see, it is a dynamic study. है ना, तुम लाइव कर सकते हो. You must have seen, है ना, बच्चे एक ऑब्स्टेटिक स्कैन जब देखते हो बच्चे हिलते हैं, है ना, तुम सिटी स्कैन में ये नहीं देख सकते, एमआरआई में नहीं देख सकते. व्हाई? बिकॉज दोज आर स्टैटिक स्कैन्स. यूएसजी इज अ डायनामिक स्कैन, लाइव तुम्हें दिख रहा है सब कुछ. ओके, तो ऑलवेज दैट स्कैन इज बेटर बट इन गुड हैंड्स. सो यूएसजी मे भी तुम्हें कुछ यील्ड दे ना दे, बट सिस्टम में भी हमेशा दे. सिस्टम में भी देगा, तुम्हें बता देगा कि भाई ये यहाँ पे एब्जॉर्प्शन बढ़ गया, ये पैराथायराइड में भी यहाँ पे एडिनोमा है या फिर इसका हाइपरप्लेजिया है, चारों ग्लैंड. ओके, तो कभी कभार क्या होगा, तुम्हारा यूएसजी और सिस्टम में भी कॉन्कॉर्डेंट फाइंडिंग्स देंगे. ओके, मतलब वो देंगे हाँ ये चार में से राइट वाला सुपीरियर ही एंड लास्ट. सो दैट इज कॉन्कॉर्डेंट. डिस्कॉर्डेंट क्या, यूएसजी बोल रहा है राइट वाला है, सिस्टम में भी बोल रहा है नहीं लेफ्ट वाला इंफीरियर. So this is discordant. So after doing system EV and USG, there can be concordant findings, there can be discordant findings. अगर concordant है तो no problem है ना. It is just like कोई पेशेंट, कोई बैट्समैन रन आउट हो गया, और रन आउट हो गया तो उसको बैट्समैन को भी पता है मैं आउट हूँ, अंपायर को भी पता है, तो उसने आउट दे दिया तो ठीक है, वेरी गुड. जब आउट नहीं दिया उसको, बैट्समैन को लग रहा है नो आई एम नॉट आउट, अंपायर फील्स ही इज आउट, सो हम क्या करते हैं, वी डू गो फॉर अ थर्ड. तो सिमिलरली यहाँ पे थर्ड अंपायर वाला इन्वेस्टिगेशन, द टाई ब्रेकर इज 4D CT is 4D CT. Okay, so this is the third scan that we use to in radiology of hyperparathyroidism: USG neck, system EV scan, and 4D CT scan. Okay, so 4D CT scan माने, okay, जैसे मैंने तुम्हें बताया कि thyroid ये CT scan is what do you say, is a static scan. यहाँ पे time bound scan रहता है 4D CT scan, where the 4 dimensional viewer is used as a time. Okay, वो थोड़ा सा आगे का है, when we get time we'll discuss how is it done and where is it done. Okay, so just remember there's a 4D CT scan. Okay, and अगर उसमें तुम्हें same findings फिर आ जाएंगे, कुछ 4D CT scan is like a tie breaker, फिर वो जहाँ बोला कि यहाँ पे बढ़ा हुआ है, so that is your culprit, you have to operate, because यहाँ पे there can be initial management would be to decrease the calcium levels or decrease the parathormone. There are some drugs, but finally अगर adenoma है, there's a tumor या hyperplasia है, so you have to go and the primary mainstay treatment of primary hyperparathyroidism remains surgery. Okay, so अगर पैराथायराइड अडिनोमा है तो इट इज गुड थिंग, मेरे को 4 में से खाली एक ही ग्लैंड निकालना है. ओके, सो इट इज अ मिनिमली इन्वेसिव सर्जरी. तुम छोटा सा सर्जरी में निकलो, इंसिजन लो, 3 सेंटीमीटर इंसिजन विल डू द वर्क. ओके, लेस देन 3 सेंटीमीटर you will remove that parathyroid gland which is a problem. Okay, but parathyroid hyperplasia, all 4 glands are enlarged. क्या कर सकते हो तुम, है ना? पूरा सब तो नहीं निकाल सकते क्योंकि थोड़ा बहुत पैराथायराइड ग्लैंड हमें चाहिए फॉर द नॉर्मल फंक्शनिंग. सो व्हाट यू डू इज बायलैटरल नेक एक्सप्लोरेशन करोगे. ओके, बायलैटरल नेक एक्सप्लोरेशन करके यू रिमूव 3.5 ग्लैंड्स. 3.5 ग्लैंड निकालेंगे, हाफ ग्लैंड यू leave it in the, okay, leave it in situ. Okay, so left wala inferior parathyroid we leave it. Okay, and rest other 3.5 we remove. Okay, and if you are planning to remove all 4 glands, okay, बहुत ही बड़े हो गए 4 glands, तो तुम निकाल सकते हो 4 glands भी. Okay, but still parathyroid चाहिए अपने को बॉडी में, तो एक ग्लैंड यू मार्सलेट. ओके, इन द सेम वे दैट वी मार्सलेटेड your gland which was removed during thyroid surgery over the brachioradialis muscle. So similarly here, when you take that gland and you put it in the non-dominant brachioradialis muscle, so eventually इसकी blood supply थोड़ी सी कम हो जाएगी. Some part will be infarcted, some part will be functioning. तो ये hyperparathyroid था, अब ये एक gland normal functioning करने लगेगा. This is the thought process with which we put that one gland in the brachioradialis. Okay, this process is known as marcellation. Okay, now अभी तुमने एक पेशेंट है जिसका तुमने हाइपरप्लेजिया एडिनोमेटस ग्लैंड था उसका. ओके, एक ग्लैंड था जो एनलार्ज था. ओके, बट बाकी सब में भी यू आर नॉट श्योर कि एनलार्ज है नहीं है, थोड़ा हाइपरप्लेजिया वाले भी फीचर है, बट सिस्टम में भी या 4 सीटी स्कैन बोला नहीं, एडिनोमेटस ग्लैंड ही था. तो you went inside, you removed that gland. Abhi you are not sure of the other 3 as well. Okay, so what will you do? There is one thing that you can do, okay, which will help you guide the further ट्रीटमेंट के भाई ये हाइपरप्लेजिया वाले ग्लैंड है तो तुम्हें निकालने पड़ेंगे, है ना? या तो फिर तो क्या होगा कि एडिनोमेटस ग्लैंड था, तुमने वो निकाल दिया, तुमने बंद किया, पेशेंट का थोड़े टाइम बाद देखा तो वापस वही सिम्टम्स लेके आ रहा है पेशेंट. इसका मतलब क्या है? यू मिस द हाइपरप्लास्टिक ग्लैंड्स during the surgery, or you didn't really work or thought comprehend this कि ये भी हो सकता है, तो इसलिए तुमने कुछ नहीं किया. What can be done intraoperatively, okay, to know whether the other 3 glands are also hyperplastic or not, or secreting more parathyroid? Anyone knows that criteria? Because this is a famous criteria, hence I'm asking. पैराथायराइड में 2-3 चीज लोगों को याद रहती है ना, बाकी सब ऊपर ऊपर से याद रहता है. जैसे कि वो सिम्टम हो गया, फिर सिस्टमिक स्कैन हो गई, एंड ये पैराथायराइड एड्रिनल है ना, वो थोड़ा सा इग्नोर्ड वाले टॉपिक्स है. ब्रेस्ट और थायराइड पे ही लोग ज्यादा ध्यान देते हैं, पैराथायराइड एड्रिनल है ना 50 Yes, Sanya.
Miami.
Miami criteria. Can you tell us what is it? इसमें आता है तुम्हारा हाफ लाइफ.
Age,
हाफ लाइफ
serum count.
हाफ लाइफ का इंपॉर्टेंस. व्हाट वाज द हाफ लाइफ ऑफ पैराथायराइड हार्मोन? पैराथॉर्मोन, इट वाज 3 to 5 minutes. तो हम क्या करते हैं कि जो 4 में से एक ग्लैंड तुमने एडिनोमेटस लग रहा था तुमने निकाला, इसका मतलब क्या है? 10 मिनट में, 5 मिनट में हाफ लाइफ है, 10 मिनट में योर सीरम पैराथायराइड पैराथॉर्मोन शुड डिक्रीज. ओके, शुड डिक्रीज क्योंकि तुमने यू रिमूव द ग्लैंड. ओके, सो वी यूज दिस. ओके, सो इंट्राऑपरेटिवली यू मेजर पैराथायराइड और लेवल पैराथॉर्मोन आफ्टर 10 minutes ऑफ रिमूवल ऑफ दैट ग्लैंड. इंट्राऑपरेटिवली पेशेंट अभी तक तुम्हारा ओपन है, तो सर्जिकल पीरियड. अगर अगर ये लेवल, अगर ये रिपोर्ट तुम्हारा लेस देन हाफ आ रहा है ना, जो तुम्हारा प्री ऑपरेटिवली तुमने पैराथॉर्मोन जो था उसके आधा हो गया, मतलब यू हैव डन द सर्जरी वेल. ओके, तुम्हारा जो एडिनोमेटस ग्लैंड था दैट हैज रिमूव्ड. बट इफ दैट इज नॉट डन, देन यू हैव टू गो फॉर बायलैटरल नेक एक्सप्लोरेशन. ओके, सो यू आर नॉट लीविंग दैट 0.5 or 5% or 10% चांसेस ऑल्सो कि भाई जो हाइपरप्लास्टिक हुए थे ग्लैंड्स वो भी यू आर टेकिंग केयर. Okay, so Miami criteria है ये कि क्या करते हो? Remove the adenomatous gland. Intraoperatively, you do your parathormone level, and if that decreases to half the maximum value in 10 minutes, you have removed the gland successfully, and if it does not, then you have to go for bilateral neck exploration. Okay, so this is Miami criteria for very important है ना, बहुत ये सब वाले MCQs वाले question. Okay, but here we are learning in depth, so this is what my criteria is. Okay, so what is the indications of surgery in hyperparathyroidism? कब तुम patient में surgery करोगे? Okay, so obviously जब symptomatic cases है तुम्हें करना ही पड़ेगा, we have to operate, but asymptomatic cases also, which are the indications? So age अगर less than 50 years है, he has a long time period, आगे जाके ये बढ़ सकता है, तो you better remove it. Serum calcium levels. Okay, if it is more than 1 gram above the upper limit, अगर बहुत लंबे समय तक 1 gram रह रहा है, you remove it. Skeletal muscle में osteoporosis चालू हो गया. We saw that osteoclastoma, patient को symptoms नहीं है. There are no clinical manifestations. So remember, guys. Okay, these are the things that you are getting after investigations. Okay, serum calcium. Then skeletal osteoporosis देखने के लिए मुझे कौन सा scan करना पड़ेगा? Anyone know?
DEXA?
DEXA.
Very good. DEXA scan. DEXA scan में score. Which score is that? T score. Okay, if the T score is less than or minus 0.25, you will go for surgery. So T score less than or equal to minus 0.25. Okay, so that is on DEXA scan. That is on DEXA scan. And kidneys है ना, creatinine clearance अगर तुम्हारा less than 60 ml per minute, because it will slowly push the patient into kidney failure. Okay, so if that is becoming less than 60 ml per minute GFR, तो फिर तुम वापस patient को operate करो. ओके, सो पोस्ट ऑप कॉम्प्लिकेशंस पेशेंट को क्या क्या हो सकते हैं पेशेंट में सर्जरी के बाद, क्या क्या पेशेंट को सर्जरी कॉम्प्लिकेशंस हो सकते हैं? यू आर रिमूविंग द थायराइड पैराथायराइड ग्लैंड, द
Can I
मेन
have hypocalcemia?
hypocalcemia. Okay, so how will you manage that? You'll give calcium supplements, okay, vitamin D
Supplements?
calcium supplements. Yes, because vitamin D is still there, which will help you keep the calcium level to be normal. Or which was the nerve which was associated with closely associated with both the parathyroid hormones or parathyroid glands?
Recurrent laryngeal?
Recurrent laryngeal. Okay, so recurrent laryngeal की injuries के chances बहुत ज़्यादा है. Okay, just to revise, since most of you are not present in my thyroid lecture, unilateral recurrent laryngeal nerve injury will lead to what?
Hoarseness.
Hoarseness, very good. So it leads to hoarseness. And external laryngeal nerve injury leads to what?
Loss of timber.
Okay, what is that one as? You are right. What is timber?
Pitch of the vocal cord.
Pitch. Okay, pitch. Okay, so loss of pitch. Why? Because we know the external laryngeal nerve supplies which muscle of the vocal cord?
Uh,
Yes, Manasini, Yash.
Cricothyroid.
Cricothyroid. Okay, it supplies cricothyroid, and cricothyroid is the, what is the function of cricothyroid?
Tensor.
Tensor of the vocal cord. Okay, so the age of, usually you know that ladies have a high pitch voice. Okay, so why? Because the cricothyroid is functioning very well. But if due to the surgery, your external laryngeal nerve is injured, cricothyroid cannot be supplied, your vocal cord can no longer become tense, and your voice will be low pitch. Okay, low pitch voice, loss of timbre, which is also known as huskiness. Huskiness. So there is a difference, huskiness and hoarseness. होर्सनेस और गाढ़ा आवाज हो जाएगा, है ना, बिकॉज ऑफ योर रिकरेंट लैरिंजियल. यहाँ पे हस्कीनेस होगा, बेस या पिच कम हो जाएगा, आवाज होर्स नहीं हो. ओके, सो होर्सनेस वी ऑल हैव एक्सपीरियंस, है ना, कभी कभार हम जब सो के उठते हैं, वी हैव अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन, योर वोकल कॉर्ड आर इडिमेटस, एंड बिकॉज योर वॉइस विल बिकम होर्स. Okay, so that is hoarseness. Here there is just huskiness, external laryngeal. Okay, and bilateral recurrent laryngeal now will lead to what? एंड ये जो यूनिलैटरल रिकरेंट लाइनेजल नर्व में इंजरी हो होर्सनेस जो होता है वो 3 महीने बाद होता है, तुरंत नहीं होता है. व्हाई? बिकॉज द अदर लैरिंजियल नर्व इज फंक्शनिंग एंड इज compensating for this. Okay, so hoarseness होने को भी टाइम लगता है, almost 3 months, and bilateral recurrent laryngeal nerve injury will lead to what?
Skylosis.
Stride. Okay, so it will lead to instant upper respiratory obstruction. Why does it cause it? What are the muscles which are supplied or recurrent laryngeal nerve कौन से muscle सबको supply करता है?
Abductor.
All the muscles except the
all.
cricothyroid.
Okay, so it supplies all the muscles except cricothyroid. But what is the most important muscle? Safety muscle that we say.
Cricoarytenoid. Posterior
Posterior
cricoarytenoid.
cricoarytenoid, which is the
It's an
adductor or abductor
only abductor.
of the. Okay, hence it is known as the safety muscle. It is known as the safety muscle. Internal laryngeal nerve injury की वजह से क्या होगा?
Aspiration.
Very good. Why?
So sensory supply
To?
to the supraglottic region.
Very good. So it is the sensory to mucosa above the vocal cords. And which is sensory to the mucosa below the vocal cord?
Recurrent larynx.
Very good. Okay. So superior laryngeal nerve and recurrent laryngeal nerve, they both are mixed nerves. Superior and recurrent laryngeal are mixed nerves. Superior laryngeal नीचे आके divide होता है in external and internal. External supplies your cricothyroid, hence it is motor. Internal supplies your mucosa above the vocal cord, hence it is sensory. But recurrent is mixed. It supplies all the muscles of vocal cord and except cricothyroid, and it is also sensory to mucosa below the vocal cords. If your internal laryngeal nerve is injured, what will happen? If food or anything else will come in the mucosa just above the vocal cord, okay, no sensations will go to the brain. Okay, why? We know that whenever we are coughing, when we are eating, and we are also talking, what will happen? The food can go into the larynx, and because the internal laryngeal nerve is intact, mucosa से जाएगा sensory sensations to your brain कि भाई कुछ तो आया है which is not air, so we start coughing wild. Okay, so if your sensory nerve is not intact, you won't come to know. Okay, and there are chances that you will spit. Right? So recurrent laryngeal nerve injury is just the revision of all the because ये जब तुम बार-बार revise करोगे तब it will be very easy or else it is very confusing. Okay, so this is just an attempt to make you revise these things again. So recurrent laryngeal nerve injury हो सकता है और क्या हो सकता है ना रिकरेंस हो सकता है रिकरेंस ऑफ हाइपरपैराथायरॉयडिज्म ओके सो रिकरेंस कैसे दो हो सकता है एक है परसिस्टेंट हाइपरपैराथायरॉयडिज्म आफ्टर सर्जरी आर ऑफ टू टाइप्स इट कैन बी आइदर परसिस्टेंट और रिकरेंट इन परसिस्टेंट योर कैल्शियम लेवल्स आर सीन टू रेज इन लेस देन 6 वीक्स अगर 6 वीक्स से कम में तुम्हारा अगर कैल्शियम लेवल्स बढ़ने लगा दैट इज परसिस्टेंट हाइपरपैराथायरॉयडिज्म एंड रिकरेंट मतलब वापस हो गया सो आफ्टर 6 months अगर पेशेंट को वापस हाइपरपैराथायरॉयडिज्म हो रहा है सो दैट इज नोन एज रिकरेंट ओके इन दोनों की ट्रीटमेंट क्या है इन दोनों की ट्रीटमेंट है यू हैव टू गिव बिस्फॉस्फोनेट्स बिकॉज यू हैव टू सेव योर कैल्शियम in the bone and also you give hormone replacement therapy okay so this is regarding your primary hyperparathyroidism